this sort of thing because I'm not actually a gambling researcher. But I have done a couple of studies looking at internet addiction and if you're looking at addiction of other things, drugs, that sort of thing. Right. Okay. So the issue was the Department of Health and Human Services in Tasmania wanted to find out what general practitioners understood about gambling, mostly because they see general practitioners as a sort of first port of call for people who've got any sort of problem. So what we wanted to do, or what the DHHS wanted us to do, was to find out whether GPs believe that early intervention as well as identification of problem gaming or gambling falls within their role of responsibility, whether they possess the knowledge and skills to detect problem gamblers, and whether they're conscious of and willing to utilise available referral pathways. So basically gambling roughly around Australia, around about 2% of the Australian population can be classified as pathological gamblers. Only a small percentage of those seek external assistance in Australia. Disclosure of maladaptive gambling behaviour is typically instigated by a state of extreme crisis produced by things like financial difficulties, legal retribution, deterioration of mental physical health, disintegration of family, interpersonal relationships, etc. Of the possible available outlets for disclosure or detection of pathological gambling, general practitioners are in a unique position. The Australian Medical Association's position statement on problem gambling in 1999 instructs, and hasn't been changed since then, instructs GPs to, 1, be aware of problem gambling and its negative impact on physical and mental health, to discuss gambling during life risk or lifestyle risk assessment, where they talk about how well do you eat, how much do you drink, do you smoke, sort of things, and undertake psychosocial assessment when maladaptive gambling behaviour is possible. Research data doesn't support the assumption that this is actually taking place. Quite a lot of people in the United States and in New Zealand, some of whom seem to be here, have reported that very many GPs aren't really confident about their role in this particular respect. So given that there is data indicating that although GPs in New Zealand and America or the US are conscious of problem gambling, at least to a limited extent, they're less likely to use this knowledge to act upon their awareness. So what we wanted to do was to establish the beliefs of Australian GPs in these particular matters, assessing those 3 aims that I had up at the beginning. So we actually ended up with 37 participants. They were GPs practising in Tasmania in Australia. I worked at the University of Tasmania prior to this data being collected. 19 male, 17 female. 1 didn't tell us whether they were male or female. Mean age was between 45 and 49. The most common age was 50 to 54. The majority of GPs' ages fell between 45 and 60, as you can see on that graph. 45 to 60. Okay, then we had a questionnaire with 4 sections. The first section was demographics. They asked about their professional status, details regarding their own gambling habits, if any, their age, their sex, etc. We asked a series of open and closed questions regarding the number of patients who consulted them with gambling problems, typical characteristics, symptoms, etc. We also gave them an attitude questionnaire, Sullivan's 2000 attitude questionnaire, which has 27 statements concerning gambling on a 5-point scale. And we got feedback or comments regarding the process of detecting and intervening in problem gambling as a general practitioner. This is how we got our 37 participants. It took us about 9 months. We contacted the practice managers of 155 operating practices in Tasmania and asked them to distribute information sheets and questionnaires. We've done quite a bit of research trying to work out the best way to access GPs, and we're reliably told that approaching the practice managers had to be the best way to do it. We distributed 2,000 questionnaires by hand to the 72 practice managers across the state of Tasmania. We made up to 6 follow-up phone calls and 3 follow-up personal visits to consenting practice managers. Is that 10 minutes? Oh, good. We've got completed surveys from 28 practices, and we collected them by hand, or we had them mail them in. The questionnaires were anonymous and took approximately 20 minutes to complete. We had ethical approval from the Tasmania Research Ethics Network. The study was a questionnaire study, and the data were analysed using either parametric means and standard errors or non-parametric median and range or frequency analyses, depending on the measures used, and we conducted a factor analysis on the attitude questionnaire. This is how we got our, or where we got our 37 questionnaires from. Just in numbers, we lost about probably 3 practices from the Tasmanian big bushfires that happened the year we were collecting the data. It's not clear we would have got a lot more people if we had managed to get those people, those practices, down on the peninsula around Eagle Hawk Neck. Generally, respondents estimated they saw between 200 and 12,000 patients per year. The mean was 3,500, and the most common estimates were between 0 and 1,000 patients per year. Don't worry, we know this is an issue. Given the mean patients seen and the poor overall return rate, perhaps the majority of GPs completing the survey were actually working part-time. To get 1,000 patients a year, you'd roughly have to be working about 6 hours a day for 48 weeks of 6 hours a day across 1 week for 48 weeks of the year. So most of the people who responded were probably part-time on the way to retiring. And the people who were not part-time were really time poor, and because we weren't offering them any money, they weren't going to fill in the form for us. This is the mean number of patients in the different categories that were seen by respondents with the percentage of total participants seen. I'll see if I can make this work. So question 6 was the number of patients with anxiety or depression. 35 participants said they'd seen people with anxiety or depression, and 17.2% of the total patients seen actually had depression or anxiety. And roughly 12% of those people were asked whether they had issues with gambling, so a very small proportion. Number of patients with high drug or alcohol use, 177 were seen by 34 respondents, and that's 6.2% of all the patients seen, and of those 6.2%, 18% were asked if they had a gambling problem. Number of patients that were seen with gambling problems, 31 participants saw somebody with a gambling problem, 15 altogether was the mean. So the percentage of total patients seen was about 0.5%, where the primary issue was a gambling problem. 16% of all the, so 0.42% of total patients seen had a gambling problem, and 16% of those came to see the GP saying, I've got a gambling problem. Very, very few. GPs were asked about whether they would discuss lifestyle issues with patients if these aren't the presenting issue. Like if you come in and say, I've broken my leg, would you then say to the patient, how well do you eat? 97% said, yes, of course I do, standard practice. They were asked if they'd ask more questions, if they had longer consultations, and they all said yes. And they were asked if this was realistic, and they all said no. So standard consultation time in Australia is about 10 to 15 minutes, depending on what practice you go to. No responding GP had gambled in the last week, but 19% of our 37 respondents had gambled in the last year, 7 of them in fact, and the average amount spent in the past year on gambling was $38. No GP reported spending any money in a 1M Banda or an electronic gambling machine. Among those GPs who did have patients consult them concerning gambling, 15 GPs, the median number of patients who consulted them was 2. Consultation regarding other medical problems in which gambling was considered, there were 24 of them, and the median number of patients were 5. So if you think some GPs, even if a GP is only seeing 1,000 a year, they're only talking about gambling with 5 of them. The median number of patients who disclosed a gambling problem during the consultation was 2. From 1 to 50 were a bit concerned about the 50 response. One GP said 50 people disclosed a gambling problem. The median number of patients was about 10 who admitted that they had a gambling problem among those who were asked about gambling. GPs thought that problem gamblers were typically female, less commonly male. They were typically aged 40 to 60 years and less commonly younger. They were typically retired. In fact, basically they were a random sample of retired, working, part-time and unemployed. Problem gamblers, they argued, reported with physical symptoms and psychological symptoms, which included insomnia, heart palpitations and chest pain, tension, multiple variable symptoms, most of which you can relate to either depression or anxiety. And psychological symptoms, they reported with anxiety, depression, stress and relationship problems. Only 20 or 56% of our respondents indicated that they were aware of possible referral channels for problem gambling, and the referral channel they favoured was psychologists, followed by Gamblers Anonymous, followed by Gambling Helpline Hotline, followed by going to the DHHS, Gambling Support Services, and finally local counselling services such as Break Even or Relationships Australia, which doesn't really deal with gambling, but nevertheless it's still a counselling service. In an average year, 3/5 or 60% of respondents reported that they had not referred any patients to any referral service for gambling. 20% had referred single patients, and the remaining 20% had referred 2 or more. No problem gamblers were referred by respondents to a further service in the week prior to the survey. So we went and asked how often they include questions about gambling as part of a patient's life history. 50% of the respondents said they did, never, or sometimes. So we've got 50% of respondents asking and 50% saying never or sometimes. When asked whether they would ask, have you ever had an issue with your gambling, which is a statement that the Gambling Support Unit thinks that all GPs should be asking, 69% indicated that they would, although they didn't currently. When asked if it would be realistic for receptionists to give patients a lifestyle survey, including the question, have you ever had an issue with your gambling, half of the respondents said it would be realistic, half of them said no way in the world. When asked about the form that referral to gambling information should take, the most common responses were a computer printout, a fact sheet and a pamphlet, And here we're probably getting an indication of the age of our general practitioners because nobody said a nap. My one's gone on to sleep, so I can't see it. I need a mouse. Never mind, I'll turn around. Just probably have to wiggle the mouse.
Whose mouse?
I'll try that.
Those two. Yeah, that one? Is it this one?
Yeah, that one.
Back one.
That one. I just can't read it from there.
I can't read it from here.
Can't read that.
You want it close?
No, that's okay.
Oh, okay.
I can see there. Okay, I'll try. That's just summarising the people who came to GPs with a gambling problem. And this is the attitude questionnaire, the questions that we asked, and the mean response. Oh, goody. Thank you. These are just the standard questions on, or the questions on the attitude questionnaire, and the mean and the standard error for these questions, so you get an idea of the kind of questions that were asked. 1 is strongly agree, and 5 is strongly disagree. Okay, the strongest disagreements were to the statements, doctors have no mandate to intervene in lifestyle practices. The mean answer out of 1 to 5 was 1.38. Doctors should seldom refer patients to non-medical professions. That's a bit of a double negative, so we might have a bit of incorrect answers to that. Undergraduate medical students can't be taught interpersonal skills. The GPs we surveyed all believed that they could be, and they did have a mandate, and they should refer people. The ones they most strongly agreed with included, when it comes to their own gambling behaviour, doctors are the same as other people. They agreed with that. Doctors can influence their patients' health and lifestyle practices. They agreed with that. It is part of my job to help people who can't cope. They agreed with that. I do not have the training to identify and help people who have difficulties with their gambling. They agreed with that. So in order to summarise these results more efficiently, we did a factor analysis. It's not 100% valid and reliable, etc., because there's only 37 people in it, but the scree plot was nice and stable, so we'll report it anyway. Got 4 factors out of it very cleanly, 4 factors, and these 4 factors are: first of all, the first factor appears to tap into the notion that gambling is not a serious problem, and also into the GP's lack of confidence regarding where to find and utilise information regarding referral processes for gambling. The second factor seems to revolve around the notion that gambling is a moral or lifestyle issue which individuals could control if they just wish to, so just stop doing it, use self-control. The third factor relates to ideas of disciplinary integrity in medicine, a lack of enthusiasm for utilising processes that are outside conventional medicine, and a belief that gambling is not relevant to medical practice. The fourth factor relates to social aspects of practice, a reluctance to engage in discussion about gambling with patients, and a belief that abstinence is the only solution, thus linking gambling, at least in these GPs' minds, to other addictions. We then did some correlations between the 4 factors and some demographic information. The only significant correlation was between Factor 4, which remember, related to social aspects, reluctance to engage in discussion, and that correlated significantly with how much time the GP had spent gambling last year. So if they're gambling themselves, they were more reluctant to talk to patients about gambling. Bear in mind, the response rate for this survey was very low, in spite of extensive and very expensive efforts to improve it. I believe that had we been able to pay the GPs, and the standard rate in Tasmanian research for paying GPs to do a questionnaire that will take them 20 minutes is $300. They won't do it for anything less. They're very important people. Their time is precious. The low response rate is in itself interesting from other points of view. It's possible that GPs who completed the form thought that they knew about gambling, although the survey results don't really support that view. And those who didn't complete the survey in spite of the opportunity didn't do it because they were aware that they weren't actually knowledgeable about gambling and they didn't want to fill in a form about it. And nobody was paying them. So in response to our original questions, do GPs believe that early intervention as well as identification of problem gambling falls within their role responsibility? Generally, yes. However, there's a significant proportion of GPs surveyed who may not. Almost a quarter of the respondents agreed that they felt it was intrusive to ask patients about their gambling, and less than half of respondents agreed that they should make time to inquire about patients' gambling. A quarter of the respondents didn't agree that it was part of their job to try and help people who couldn't cope, and a quarter of the respondents agreed that they had difficulty seeing problem gambling as being within their mandate. In response to the second question, do GPs possess the knowledge and skills to detect problem gamblers? It's probable that many of the GPs surveyed do indeed possess considerable knowledge and skills if one considers their responses to questions about presenting conditions and referral pathways. However, the evidence makes it very clear that the respondents' lack of confidence in their ability to detect problem gamblers and that they are dissatisfied with their perceived knowledge of problem gambling and interventions. 65% of the surveyed GPs agreed with the statement, "I do not have the training to identify and help people who have difficulties with their gambling." Only 3 of the respondents had received formal training and education in the area. Are GPs conscious of and willing to utilise available referral pathways? The answer to this one seems to be that in general, yes, with few showing any level of concern about loss of control or dealing with non-medical professionals. However, the important caveat to this response is that in order to demonstrate a willingness to use referral pathways, it's first necessary to detect patients with a gambling problem. GPs are not confident of their ability to make this judgment or its appropriateness, which could very well contribute to the very low presentation and referral rates reported. Furthermore, while GPs may know of referral agencies and have positive views of different treatments' effectiveness, it's very clear that they have considerable concerns regarding their interaction with these agencies. Overall, GPs don't see many people with gambling difficulties, and if they do see them, they don't recognise them. Although they do ask lifestyle questions of patients, they don't generally include questions about gambling in this process, arguing that short consultations times probably preclude that. In general, GPs are not confident about their knowledge regarding referral processes for gambling. They believe that gambling is a lifestyle issue under the control of the patient and that gambling is not actually relevant to medical practice. Possibly as a result of these beliefs, and in particular their lack of confidence in the area, GPs are reluctant to discuss gambling with their patients. And although the numbers of respondents are fairly small, the factor analysis, although it's done with a very few number of people, is probably about as valid and reliable as we could get, and suggests that some GPs have inappropriate and incorrect views on the relationship between gambling and addiction. We were given money to conduct this program by the Gambling Support Program from the Department of Health and Human Services in Tasmania. Thank you.